सर हवं तर तुम्ही रिजॉईन व्हा.
Start.
तृप्ती मॅम.
Good evening and welcome everyone. On behalf of Maharashtra Academy of Pediatrics and Maharashtra State Academy of IP branch, Nashik IP branch and Nashik AHA branch, I welcome all the dignitaries. I welcome today's speaker, Dr. Shekhar Dabadkar sir, Dr. Preeti Fatale madam. I welcome all the office bearers of Maha IIP, Dr. Ram Gopal Chejara sir, respected President Maha IIP, Dr. Amol Pawar sir, Secretary General Maha IIP. I welcome Dr. Rajendra Kulkarni sir, who is MMC observer for today's session, Dr. Sangeeta Loda madam, who is AHA Nashik president, and I welcome all the delegates for today's session. We are happy to announce that this month we will be completing 2 successful years of the PATH webinar series. And when we look back at those 2 years, we are able to complete many important topics which are important for day-to-day practice for pediatricians related to adolescent health. Today also we have come up with 2 important topics, that is obesity and suicide. So before we start up with the session, I request Dr. Amol Pawar sir, Secretary General, Maha IIP, to address the delegates. Dr. Amol sir.
Okay. Thank you, Trupti. I once again welcome our both the expert, Dr. Shekhar Dabadkar sir, past Vice President of West Zone, and Dr. Preeti Patale madam, who is child obesity expert from Sambhajinagar. Then all the senior pediatricians of Maharashtra IIP, today's MMC observer, Dr. Rajendra Kulkarni sir, who is past executive board member of National IIP also, and also AHA Nasik President Dr. Sangeeta Loda ma'am, all the executive board members, Dr. Mateen Sheikh, and many of those who have joined, and also many of the branch office bearers of various branches of Maharashtra IIP, they have also joined. Welcome to all of them. Then I welcome all the pediatricians, all the IIP members of Maharashtra as well as India, and PG students, and all the delegates who have joined from across India for this innovative topics on pediatricians action plan for teenagers healthcare. This pediatrician action plan for teenager healthcare was started 2 years back by then President Dr. Ramakant Patil sir, who was Maharashtra IP president, and another expert who is adolescent expert of not only Nasik but India as well, Dr. Atul Kanikar sir, and under their guidance, Dr. Trupti, Dr. Sulabha, Dr. Sucheta Malhotkar madam, Dr. Reena, Dr. Sangeeta ma'am, Dr. Suravse sir, they all have came together. They have selected topic under the guidance of Dr. Atul Kanikar sir. And then we executed various, I think more than 20 webinars we have conducted in last 2 years, and various experts from all over India, various adolescent experts from all over India, they have helped us in deliberating science to all the pediatricians of India. So I once again welcome both the experts and all the delegates, and I hand over again back to Trupti for further proceedings.
Thank you so much, sir. I now request Dr. Sangeeta Lodha, madam, who is President AHA Nashik and Chairperson WPF, to address the delegates.
I'm sorry to disturb. Ram sir has also joined.
Ram
Okay.
sir is there.
Yeah,
Yes.
yeah, I guess.
Ah.
I request Dr. Ram Gopal Chezara, sir, President Maha IIP Nashik, to please address the delegates.
Actually, his name is not visible. That's why this happened.
Yeah.
Yeah, I think so. Good evening, friends. Welcome again after a long gap because we were busy in the Mahapedicon and Central IIP election also. So, sorry for that delay. I think Dr. Amol has already updated about the path. On the behalf of Maharashtra IIP, I welcome Shekhar Dabadkar sir and Dr. Preeti. Welcome all and congratulations to the team Nashik for successful conducting the path episode. Thank you. Over to you, madam.
Thank you so much, sir.
Trupti, Dr. Sanjay Pakmode sir has also joined.
Wow, great.
So please call him. He is president-elect right now and next year president of Maharashtra IIP.
Yes, sir. Dr. Sanjay Pakmode, sir. Your
Am I
blessings
audible?
for today. Yes, sir.
Yes,
Yes,
sir.
sir. Please.
So good evening, all of you.
Good evening, sir.
Oh,
Good evening.
Good evening.
After the Mahapedicon 24 in Nagpur, again back to the academics. So, Dabadkar sir, namaskar. Ram sir, namaskar.
Yes.
How are you, Sanjay?
Yes,
Congrats,
fit, sir.
congrats,
Thank you,
congrats.
thank you. And welcome all of you for the today's session. And Amol, again, I welcome you.
Yes. You are muted, sir. You are muted, sir. Please unmute.
So without wasting time, I again welcome all the speakers for the today's meet, and I request Tripti ma'am to start his session.
Yes, yes.
Yes.
Thank
Thank you, sir. Thank you.
Thank you so much, sir. I think Dr. Sangeeta, ma'am.
Good evening to all of you. And really, it's a very proud moment for all of us that we have successfully completed 2 years of this path, Pediatricians Action for Teenager Cell. And the same legacy will be continued in 2025. My all the best wishes for the team of Maha IIP, Maha AHA, and AHA Nashik. Big buck up for all of you. Thank you.
Thank you, ma'am.
Tripti, Dr. Rajendra Kulkarni, sir.
Yes, Dr. Rajendra
Yes, sir.
Kulkarni sir is also there. Yes.
So please address
Please invite him.
delegates.
Good evening, everybody. It's my pleasure to witness this 20th edition of Path with successfully going on. Even I think in last 3-4 sessions, I was fortunate to be MMC observer in this. This session is special because my old friend Dr. Dabadkar is the speaker. Old friend, means he is not old, our friendship is old. Namaskar, Dabadkar sir. So without wasting much time, we both start talking. The webinar itself will last for 2 hours. So I congratulate team Maha IIP and AHA Nashik, Amol, Trupti, Sangeeta ma'am. So please keep up the good work. Congratulations and all the best for future deliveries. Thank you. Over to you, Trupti.
Thank you. Thank you so much, sir. Amol, sir, should we start? Yeah. I think we should go ahead. So, dear all, in today's era of artificial intelligence, non-communicable diseases.
Tripti, 1 minute.
Yeah, sir.
Sorry to disturb you. I was muted. Dr. Ravindra Kutte sir is there, I think. We can invite past IMA president of Maharashtra. Dr. Ravindra Kutte. He is visible. Kutte sir.
Yes, good evening. Good evening,
Yes, sir.
everyone.
Please have few words with us, sir.
Really congratulations, the team IAP Maharashtra. During my presidency also, IMA and IAP had many sessions jointly organized, successfully organized. My best wishes. Thank you very much.
Thank you, sir. Trupti,
Thank you
please
so much.
continue. Yes.
Yeah. So,
Continue further.
yes. So, dear all, in today's era of artificial intelligence, the incidence of non-communicable diseases is a major public health concern. Out of the non-communicable diseases, two rising demons, that is obesity and depression leading to suicides, need timely identification, timely referral, and multidisciplinary management. So let us begin with the first session, that is obesity. To enlighten us about the topic, we have with us Dr. Preeti Fatale, Madam, who is doing pioneering work in the field of obesity. Madam is exclusively practicing pediatric obesity, childhood obesity since 2006. She is National Fellow of SCOPE, that is Strategic Center for Obesity Professional Education of the World Obesity Federation. She was a task force member to fight against non-communicable diseases by Maharashtra government. Madam is being faculty in many state, national and international conferences. Her recent contribution was for the World Pediatric Conference in 2024, which took place in Japan. And she has won many awards. She has many national, international publications. I invite Dr. Preeti Fatale, Madam, to enlighten us about the comprehensive management of childhood obesity. Over to you, Preeti, ma'am.
Thank you, Dr. Tutri, for your kind word of appreciation. I kindly request your patience regarding my hoarse voice because it is very difficult and it is going through since last 1 month. But I hope it's my proud privilege amongst all the August gathering. Pallavi Madam, can I share my screen?
Yes, ma'am, please. Yes, ma'am. It is visible.
Let me take this opportunity to congratulate Maha IIP for successfully completing the 2 years of path and working on the most needed practical diseases for the pediatrician. Thank you for this opportunity and especially congratulate for the Maha IIP and respected all IIPNs for taking this topic into consideration for today's talk because it is a need of our. We all agree that childhood obesity has been one of the most serious public health challenges of 21st century. Let us change the perspective from me to we, that is address obesity together, and I really once again congratulate for taking this initiative. Depending upon the data from 2000 to 2016, that is the projected figures, projected percentage for the children with high BMI for the age group 5 to 19 will be predicted to rise from 22% of the global population to 39% of the global population by 2035. That is nearly the double. And this needs actions very urgently. I don't know, the slides have been stuck up. Yes. So, the prevalence of obesity is rising fastest in emerging economies where the double burden of malnutrition prevails, that is, like in India. The World Obesity Atlas has published that annual growth rate in the projected number of adults with high BMI from 2020 to 2035 is 4.1% against the 6.2% the projected number of children with high BMI over the same period. That speaks of definitely the annual growth rate is more for the children as compared to adults. Let us define obesity. Obesity, it is a chronic relapsing multifactorial neurobehavioral disease wherein increase in body fat promotes adipose tissue dysfunction, abnormal fat mass physical forces resulting into metabolic, biomechanical and psychosocial health consequences. As you all agree that one pandemic has added fuel to the another pandemic, this is the electronic medical records which speaks of the prevalence of childhood obesity had jumped to 44% globally, and which is not different in our country also. Many of the patients used to say that when we ask कि from since the child is putting on weight, they used to say that मैडम कोविड के पहले तो इसकी हड्डी दिखती थी, अभी इसका वेट गेन इतना फास्ट हो रहा है. So this speaks of, and that proves also, one pandemic has added fuel to another pandemic. And I quote the example of one of my patient who has put almost to the tune of 40 kg after the COVID, and who was previously normotensive, non-diabetic. He turns to hypertensive and diabetic after putting 40 kg weight after COVID. This speaks of this is an urgent need to have this action on the exponential rise of childhood obesity. As we all aware that BMI is the tool to classify the children with high BMI. Below 5 years of age, WHO growth standards are used to classify the children. From 5 to 18 years, the Indian Academy of Pediatrics IP growth charts are there to classify. Adult equivalent of 35 is being classified as overweight, and adult equivalent of 27 is classified as obese. In addition to this, age and sex specific reference curves for the waist circumference for Indian children been published, and the cutoff values of 17th of waist circumference percentiles are used for screening for the metabolic syndrome risk. In addition, this is an body composition analyzer, that is the BIA, bioelectrical impedance analysis, which is used to help to have the quantity of fat, its distribution, especially useful in adolescents where the body composition is always changing. So this is a review of the Pediatric Endocrine Society recommendations. Nowadays, adolescents with BMI 30 plus are routinely be seen. Severe obesity is further classified into 3 classes depending upon the BMI centile or the BMI, whichever is low for the age and sex. So let us review the causes. Obesity is influenced by genetic, epigenetic, and environmental factors. Why we are worrying about the obesity? Because childhood obesity often tracks into the adult obesity, resulting into the comorbidities like endocrinopathy like diabetes, metabolic syndrome, PCOS, infertility, hypertension, coronary artery disease, vascular complications, NAFLD, recently been nomenclature as MASLD, hormone influence cancers, OSA, depression, and anxiety. As Dr. Trupti rightly said that this is the era, in an era of artificial intelligence, all the NCDs are taking toll. So let us see what are the critical periods for the development of childhood obesity. Let us start from that is gestation, early infancy. Second phase is the period of adiposity rebound age, that is between 5 to 7 years of age. That speaks of the age at which the body fat started increasing after reaching its lowest value in childhood. And third is the adolescence. So what is the importance of critical period? Because the critical periods, these are existence of critical period should serve to focus the preventive efforts on these developmental stages. Let us explore the cases of these critical periods. The extremes of birth weight, these are the forerunner for the childhood obesity. The infants, all will depend upon the maternal nutrition. Undernutrition and overnutrition of the mother is going to reflect in the well-being of the fetus in future also. That is both extremes of birth weight. These are the forerunner for the childhood obesity. Not only obesity, but they will be the victim for the type 2 diabetes and cardiac disease in future. So let us start the early infancy. A 8 months fifth female child of second degree consanguineous marriage delivered by C-section. Mental milestones were normal, brought with complaint of repeated respiratory tract infection and hypophagia. Previous sibling had died because of the severe infantile obesity. Anthropometrically, the girl found to be obese. After doing the routine investigations, we did the serum leptin levels, which found to be low. Then we proceeded for the gene sequencing, and which revealed the presence of a homozygous likely pathogenic variant in the left gene. That speaks of she is a case of leptin deficiency. So one should keep in mind that severe infantile obesity, we have to keep in mind of either genetic or endocrine causes. The second phase, that is the phase of adiposity rebound age. A 6-year boy brought in with complaint of rapid weight gain, increased appetite, blackening of skin at the nape of neck and armpit, which is a hallmark of insulin resistance and been designated as acanthosis nigricans. He loves the junk food, chocolates, desserts, no outdoor activity at all, and delivered normally. Father was morbidly obese with family history of diabetes, obesity in grandparents. Anthropometrically, the boy is obese tall. This is very important. When we are dealing with the obese kid, we have to have that stature is very important. That is a height velocity. Obese tall always goes in favor of the exogenous obesity, and the boy found to be on investigations normal. That speaks of he is a case of exogenous obesity. Third, that is the third critical period, that is the adolescence. He is a 15-year boy brought with complaint of rapid weight gain with reduced height gain. It is very important. Many of the time we used to see that the children who are been nutritionally good, they are always good in weight as well as height. But this boy brought with complaint of rapid weight gain with reduced height gain. The boy is delivered normally with birth weight of 4 kg. Mother was a case of gestational diabetes mellitus. Mother and father both are obese with family history of insulin resistance in form of diabetes, obesity, and hypertension. Anthropometrically, the boy proves to be morbidly obese but short as compared to MPH. I am highlighting this obese with short stature, and SMR was prepubertal. On investigations, he found to have thyroid function test normal, because always we keep in mind that obesity with short stretches, first and foremost, we have to rule out the thyroid function test. And thyroid function test was normal. We did the gonadotrophin because considering his SMR, which was pubertal on first examination, and testosterone found to be low. This case highlights the importance that children, that is especially the boys, will land up with the delayed puberty because of the obesity, as against the girls land up with an early puberty. She is a girl, 9-year-old, complaining of weight gain with breast development. On examination, found to be obese tall. That speaks of she is nutritionally good, more of exogenous obesity, and on examination, SMR was with breast development B4 and pubic hair at first position. All investigations normal, including sonography we did to rule out all the other causes. And after we assure the parents that this is all because of obesity, the girl is having early puberty. Many of the time, the adipose tissue, excess of fat, secretes estrone hormone that will cause an early development of breast in children. So that is very important. After assuring the parents and started the lifestyle modifications with proper medications, after 1 year of significant weight loss, the SMR was in the same stage. That speaks of tackling obesity will have the solutions for the pubertal development either early or delayed. Many of the time, parents used to bring the children for associated complaints. That is, and the girl is brought with complaint of blackening of nape of neck along with a blackening at the armpit also. Many of the time, girls used to bring with complaint of acne, hirsutism, or boy used to bring with breast development, that is gynecolipomastenia, or the external genital problems, that is pseudomicropenis. So all these associated complaints may relate to your weight. But at the same time, we have to convince the parents also. These problems have to be tackled at the going at the root cause, that is for the obesity. Nowadays, we are seeing many more cases of the PCOS. The diagnosis of PCOS in adolescents is particularly very challenging. It is the diagnosis by exclusion. Presence of at least two of the following three criteria, that includes irregular menses, that is less than 9 cycles per year, hypoandrogenism, clinically either acne or hirsutism, biochemically with increased serum testosterone levels or polycystic ovaries on sonography, that 2 of 3 criteria will suffice to diagnose the case as a PCOS. Many of the time, the girls used to bring with blackish velvety skin, that is the hallmark of insulin resistance, as we earlier discussed. And then after exploring the history, they used to say that they are having the irregular menses also. Why we should worry about the PCOS? Because the comorbidities with PCOS are diabetes, hypertension, dyslipidemia, infertility, and atherosclerotic heart disease. After exploring the exogenous obesity, let us move to the obesity due to endocrine disorders. Many of the time, patient used to bring multiple reports of thyroid function tests and all used to be normal. So when to the label a case of obesity due to endocrine disorders, let us explore the case. A 11-year boy brought with complaint of stunted growth, constipation with puffy face, delivered normally with family history of thyroid disorders in maternal grandmother and aunt. On examination, he found to be obese short, that is height centile was 3 to 10 as compared to the MPH, which was 10 to 25 centile. On investigation, found to have the TSH more than 100 milli-international unit per ml with FT4 less than 0.40. That speaks of he is a case of obesity with primary hypothyroidism. Once again, I am highlighting that obesity with short stature, we have to look into the matter for either endocrine or genetic causes. This is another case. 12-year boy, known case of asthma, came with history of rapid weight gain, easy fatigability with puffy face. He was being treated for the asthma with steroids long back. Father was obese, diabetic, mother morbidly obese. On examination, he again proved to be a case of morbidly obese with BMI to the tune of 35.8 kg per meter square, short as compared to MPH. On investigation, after doing all normal investigation, basal cortisol we did and it found to be low. This is a case of drug-induced Cushing. So after exploring the exogenous obesity due to endocrine causes, let us move further for the syndromic obesity. Here, a 9-year girl brought with complaint of weight gain with poor height gain, delayed milestones, scholastic backwardness. On examination, found to be obese, short with facial dysmorphism. After the normal routine investigation, we did the genetic testing, which proves that heterozygous pathogenic deletion on chromosome 15, which is a hallmark of Prader-Willi syndrome. Thus, all these cases proved that obesity with short stature, we have to rule out endocrine or the genetic causes. Let us study the structure approach for a child with high BMI. Once you find a child with high BMI, after having a proper detailed history and physical examination, if both the things are normal, we have to evaluate for the obesity associated comorbidities and start the lifestyle modification and specific treatment of the comorbidity if present, if they are there. And observe for the weight loss or the weight stabilization, because children always grow in height. Even if the numbers will remain same, but as they are growing in height, the BMI starts reducing. In such a case, we have to maintain the support for the lifestyle modification and comorbidity treatment. If there is a continued weight gain more than 6 months, we have to consider the pharmacotherapy or surgery. But unfortunately, data supporting use of these interventions are limited to the pubertal individuals. If history and physical examination reveal some abnormality, for example, in cases of attenuated growth velocity, we have to think of endocrine evaluation like thyroid function test, basal cortisol, growth hormone evaluation. In cases of neurodevelopment abnormality or severe hyperphagia, we have to go for the genetic evaluation. In case of CNS injury, we have to think of hypothalamic obesity. In cases of antipsychotic drug also, we have to reevaluate the drug and we have to replace with the weight-friendly drugs. If a child found to have a developmental delay, then we have to go for the karyotyping. And if the karyotyping is positive, think of Prader-Willi syndrome as we earlier saw the case. And if there is a negative, along with the ophthalmic manifestations like retinal dystrophy, photophobia, we have to think of Bardet-Biedl syndrome or Alström syndrome and so on. And if there is no developmental delay, we have to measure the leptin. If positive, we have to label the case as congenital leptin deficiency and other genetic dysmorphia. Why we should worry about the accelerated obesity pandemic? Because childhood obesity is a very important factor for controlling the exponential rise in rising burden of the NCDs. The estimates suggest that by 2035, if no interventions been done, 68 million children will experience hypertension, 27 million will experience hypoglycemia, and 76 million will experience low HDL cholesterol. And unfortunately, all these children will be living in middle income countries and for the most part of their condition not being detected or treated at all. So we have to be more alert about all the things. I have published my study regarding the comorbidities in a child weighing more than normal, that is overweight and obese, in IJEM journal. I have presented a poster at World Diabetes Congress at Melbourne, Australia, regarding the clinical reversal of type 2 diabetes in 2 obese children as well as the obesity related comorbidities. Let us explore the child with high BMI with type 2 diabetes. A 9-year boy brought with complaint of rapid weight gain, easy fatigability, sluggishness, delivered normally with birth weight of 3.5 kg, mother, father both obese, family history of diabetes in both maternal grandparents. Anthropometrically, boy found to be obese tall. That again speaks of he was nutritionally very good. SMR prepubertal on investigation, we can very well see his protuberant abdomen, that is the central obesity. On investigation, found to have the high fasting blood glucose with A1C 7.3 with C-peptide normal. That speaks of with urine ketone negative. He was a case of type 2 diabetes. We did the family counseling, start the lifestyle modifications along with the required medications, and to the surprise, after 15 months of lifestyle modifications and pharmacotherapy, the BMI came down from 27 to 21 with A1C from 7.3 to 5.1. This is an early intervention is definitely will cause the reverse of comorbidities in obesity. These are the
Ma'am, you are muted. Preeti ma'am, you're not audible.
Preeti ma'am, please unmute.
Preeti madam. I think we are not also
I will
audible.
call. I will call.
Yeah.
Please call her.
Priti ma'am, you are not audible.
She is not lifting phone.
Preeti ma'am.
Priti ma'am,
Preeti
you are
ma'am.
not audible. You are not audible.
Audible नाही. Audible नाही.
मला वाटतं आपला आवाज पण त्यांना ऐकू नाही जात आहे.
हा.
मॅडम एकदा म्यूट करू का त्यांना मी?
हा
म्यूट
म्यूट
करा.
करा.
केलं. मॅम काइंडली अनम्यूट युअरसेल्फ. प्रीती मॅम.
मॅडम ऐकू येत नाहीये. मोबाईल पण उचलत नाही त्या. मॅडम त्यांच्या मिस्टरांचा नंबर नाहीये माझ्याकडे नेमका. फोन उचला. त्यांना आपण दिसत नाहीये मला वाटतं.
प्रीती मॅम कॅन यू हिअर अस? प्रीती मॅम. बापरे नाही सर.
त्यांनी मिनिमाइज करून ठेवलं असेल, असं काहीतरी झालं.
खरं तर छान बोलतायत त्या.
या
मॅडम ऐकू येत नाही. ऍक्च्युली त्यांची सिंगल विंडो असेल, आपण दिसत नाही त्यांना.
हा एक्झॅक्टली.
अरे सर रेकॉर्ड होतंय आपण बोलतोय ते.
हा ठीक आहे ना, आता काय करणार.
पल्लवी मॅम, सर रेकॉर्डिंग बंद करायचं का तात्पुरतं?
थोडा वेळ करावा असं मला वाटतं.
या
मॅडम लाईव्ह बंद पडेल.
प्लीज
अच्छा,
वेट,
ओके
मैडम को इन्फॉर्म किया है.
Yeah, na?
अच्छा,
Wow, great,
ओके,
great.
थैंक यू सो मच, थैंक यू.
Great, great. Thank you, thank you. अनम्यूट करा मॅडम आता त्यांना.
अनम्यूट करने के लिए
बोला मॅडम.
या प्रीती मॅडम.
तृप्ती परत फोन करा त्यांना.
प्रीती मॅडम, यू आर नॉट ऑडिबल.
somebody is there.
या
मॅडम आता ऑडिबल नाहीये तुम्ही. तुम्ही लेफ्ट व्हा, मीटिंग लेफ्ट करा आणि परत रिजॉईन करा.
ओके ओके.
आला आवाज आला.
आवाज मॅडम आवाज
आला,
आला.
वी आर ऑडिबल.
मॅडम मागे जा, स्लाइड 4-5 स्लाइड मागे जा तुम्ही.
ओके, जस्ट अ मिनिट.
इथून सुरू करावं लागेल तुम्हाला परत.
हो सॉरी.
काय नाही,
पहिल्यापासून केलं तरी चालेल. आय विल ड्रॉप माय लेक्चर.
नाही.
4-5 स्लाइड मागे जायचंय सर त्यांना.
प्लीज.
मागे
नाही, याच्यात काही प्रॉब्लेम नाही. फक्त मागे जात राहा. बस.
जाता येते.
हा,
येस.
जा मागे जा मॅडम, मागे जा.
हो, याच्या आधीची स्लाइड सर.
मागे जा. हा, इथून सुरू करा मॅडम.
येस.
येस.
इथून.
वेट.
थँक्यू व्हेरी मच. थँक्यू.
आणि फोन चालू ठेवा म्हणजे आम्हाला सांगता येईल परत. इथे
Sorry,
कोण कोणाचा
sorry,
आवाज कधी
silent
बंद
वर
करेल
होता.
ते सांगता येत नाही.
वेलकम बॅक अगेन मॅडम.
हो, थँक्यू सर. आता येतोय ना सर आवाज?
येस, कम्प्लिटली.
The management goal should include the early personalized interventions which can prevent or treat the obesity-driven disease. The intervention do not negatively impact the growth or development, which is very important. Obesity requires lifelong management with multimodal treatment for example, medical nutrition therapy, exercise, behavioral therapy, which is very important for the adolescents especially, pharmacotherapy and bariatric surgery as per needed. Children and adolescents deserve access to all advanced therapies as well as they deserve the same access to quality care that is provided for other chronic diseases, which is very important. Comprehensive obesity care for children deserves the adequate healthcare insurance coverage for the obesity treatment. The goal should be divided, that is in the patient or family level, and another that is at the clinical level. Family counseling, it is very important because many of the times the parents used to blame the children, but we have to ensure that it is not the patient's or family's fault, but it is a chronic disease which requires a lifelong care, and because it has its own psychological and physical health implications, and one should focus to improve the body image and self-esteem, not to blame them. And the clinical goal should to improve the quality of life, that is present and future health. Genetic issue impacting the diseases should be addressed, improve the body composition, and see that it should be reached near normal, and ensure that even a loss of 5 to 10 kg body weight positively impacts the obesity driven diseases, which may be age and gender specific. Pharmacotherapy has a very limited role because though it is a disease, it is not the disease of drug, it is a disease of lifestyle modification. FDA has approved Orlistat, that is the lipase inhibitors, and GLP-1 analog, though metformin is not been approved by FDA for the obesity, but off-label use has been widespread. Obesity due to endocrine disorders or obesity-associated genetic syndrome needs specific treatment for the underlying pathology. So to conclude my talk, to downslope the exponential rise of childhood obesity, we have to increase awareness at multiple stakeholders, ensure appropriate weight gain during pregnancy, practice exclusive breastfeed, and till first 6 months and continue till under 2 years of age, trace the high-risk infants and children, educate, target their family and school. Policy maker should make compulsory school ground, should implement national canteen policy for all government, non-government schools, support the behaviors of children around the healthy eating, physical activity, sedentary behaviors, and sleep, regardless of the current weight status, which is very important. Enjoy healthy life. So, to conclude my talk with the take-home messages, obesity, it is a chronic, relapsing, multifactorial neurobehavioral disease. Obesity under 5 years of age is most likely due to monogenic, syndromic, genetic, or endocrine disorders. Being a pediatricians, we have to address the thin line between the catch-up growth and the accelerated weight gain. Nutritional obesity, along with its comorbidities, can be reversed. Overweight and obese children are more likely to stay obese into adulthood and develop NCDs at a younger age. High BMI in children is associated with spectrum of metabolic abnormalities. Documenting these conditions in pediatric population underscores the urgent need for early detection, prevention, treatment strategy to mitigate the long-term health risk. The involvement of family, multiple stakeholders is crucial for effective childhood obesity interventions. We used to conduct the awareness campaign on occasion of every World Obesity Day. And thank you once again for this opportunity. The wish is hard to downslope the exponential rise of childhood obesity. The dream is big, but together we all can make it happen. Thank you so much.
Thank you. Thank you so much, ma'am, for such a wonderful, very well structured, very informative approach to obesity and the various case series out of your vast experience has really enlightened us very well about the topic of obesity. And this again highlights what as a pediatrician, what we can do in our office practice, at least the cases of exogenous obesity. Importance of healthy lifestyle can be addressed regularly. Screening can be done regularly and early intervention will definitely prevent this demon of obesity. So thank you so much once again.
Thank
Now
you.
let
I
us start.
sincerely apologize for extending the time because I was not knowing at all. Thank you.
No worries, ma'am. We
Thank
have
Ma'am, you
time.
were in time actually. 30 minutes were allotted to you and you finished in 28 minutes only.
Yes.
With some disturbance.
No problem. But it
No
was
problem.
very good lecture.
Yes,
No
topic,
problem.
yes.
No
Thank you
problem.
so
I will
much, sir.
finish within 10 or 15 minutes. No problem.
Yes.
Thank you so much, sir.
No, sir, you have to
No,
talk.
sir, you have time.
Sorry,
have
I'm
talked-
saying thank
you
you
have
for
to-
the appreciation,
you have
sir. You
time
can
till
have your
10:30,
own
sir.
time. On the contrary,
Yeah.
we will be very happy to hear you, sir.
Yes.
No.
So, dear all, let us move towards our second topic, which is again very important, a slowly rising epidemic of depression leading to devastating consequence of suicide in teenagers, which is the second leading cause of death in teenagers worldwide and even in India. So, for the same topic, we have with us very well renowned senior pediatrician, Dr. Chandrasekhar Dabadkar, sir, from Malad. Sir was National Vice President West Zone IP in 2020. He is presently working at his Dabadkar Hospital in Malad district, Raigad. He was
Mahad.
Yes, Mahad. Executive board member CIP in 2012 and 2013. He was AHA district president Raigad IIP in 2021 and 22. He has many awards. He was conferred FIP at Indore conference in 2014. He was also conferred with Exemplary Medical Practitioner, Best Public Education Award, Dhanvantari Puraskar, and many other awards. He is having his main interest in public health education, has conducted many parenting programs throughout the state and outside, and also health education programs for paramedicals in Raigad district. So I invite Dr. Shekhar Dabadkar sir, Chandrasekhar Dabadkar sir, for today's important topic of suicide in teenagers. Over to you, sir.
Thank you so much.
So will you make it a slideshow?
Yes. Just
Yes, sir. It is
just
possible.
wait for a minute because it's overlapping. Something is going wrong. All photographs are overlapping. I don't know what happened.
Okay. Sir, other windows are open?
I don't know. Chalo, whatever it may be.
It's visible from our side. So go ahead, sir.
Yes.
Yeah.
So good evening, everybody. It's really pleasure to meet all our friends from IIP. I am giving lecture after a very long time because of so many reasons. President Dr. Ram Gopal, I don't know whether he's present at or not. My young friend, Secretary Dr. Amol Pawar, Moderator Trupti, MMC Observer, my old friend Dr. Rajendra Kulkarni, Dr. Atul Kanikar, Dr. Sangeeta Lodha. You are doing extremely good work, Sangeeta Lodha and Sulbha at Adolescent Nasik. Please accept my compliments. Dr. Sanjay Pakmode, Dr. Kute, and everybody. Dr. Tripti, please accept my compliment. Dr. Patale, please accept my compliments. You talked so nicely, so nicely.
Thank you.
It was a very good academic lecture, and I am attending this lecture after a very long time. Frankly speaking, I am going in depression now, and I am having suicidal tendency because such a nice lecture. Come what may, whatever it may be. Yes. Why suicide we should study? Why pediatricians should study this suicide? This is domain of psychiatry and psychotherapist and everybody else. Why? But frankly speaking, my dear friends, we know children up to the age of 18 years and self-harm and suicide are major public problems nowadays in adolescents. And rate, if you open any newspaper, maybe either a state newspaper, local newspaper, or national newspapers, you will see that at least there is one news of committing suicide by an adolescent. Causes are very many. We will not go into that. But it is said that suicide is the second leading cause of death among teenagers and young adults. I don't know why it is not visible to me. Whatever it may be, just we will finish as early as possible. Okay. I don't want to go in statistics as such because statistics is such a vast topic, but it is mentioned in Nielsen and that too in 19th edition. Now we are in 22nd, 23rd edition. That in last 6 years suicide rate is quadrupled, almost in 15 to 20 years in males and doubled in females. Probably this figure may be large at present. Why Indian teens? It is said that it is category proved, and this was a paper in Lancet that in India, rate of adolescent suicide is really at is very high. In one of the paper, it is said that Tamil Nadu was 148 per 1 lakh, and as compared to UK, it was hardly 2.1 suicide per 1 lakh. It is said that almost 50 to 75% of deaths in adolescent girls and about 25% of all deaths in boys aged 10 to 19. It is also said that suicidal ideation is more common in female, but successful suicide is more common in males. Again, reasons are very many. I remember a news from Delhi that one child who was differently abled and his parents were discussing suicide, and when this discussion was going on, this child directly jumped from 10th floor. So even in Delhi, just we talked regarding Tamil Nadu and southern states, but even in Delhi, it is proved that suicidal rate is very high. As I said, we will not go in these statistical details as such. But most important cause of suicide or underlying cause of suicide is depression and depression and depression. In adults, it is said that almost 80% patient of depression they commit suicide, whereas in pediatric practice, these statistics may be same. It is more common when there is any previous suicidal attempt, history of suicide.
बुखार वाली बंद कर दो, जब बुखार आएगा तब देना.
Sir, you are muted. Dabadkar sir, please unmute yourself. Yeah. Yes.
A family history of psychiatric disorder. So whenever we see a case of attempt of suicide or any case of unsuccessful suicide, we should not forget to take detailed family history also, because psychiatric disorders are more common in children who try to attempt suicide. Causes, there are so many causes, we will not go in detail, but if there is good support network, maybe peers, maybe parents, maybe friends, maybe relatives, maybe any religious association, probably suicide rate in that community or in that children is definitely less. Whereas if there are no such good network, because I have witnessed so many times, both parents are very busy, or suppose divorce is there, single parent is there, and on the top of it, if there is no communication, then chances of suicide in that child are more. As you know well, there are a lot of problems in adolescent. It is called as endocrinal storm. Already child has some psychological problem. Child is developing, there is sexual development. He develops attraction towards another sex, and on the top of it, academic pressures are there. And because of this academic pressure, this changes, endocrinal changes, obesity and other causes. If on the top of it, if there is parental divorce is there, it is observed that these are the causes where chances of suicide are more. If there is parental divorce, physical or sexual abuse in school or college, emotional neglect for so many reasons, exposure to domestic violence. Probably I forgot to tell you one case why I talk on this topic in so many schools. Because in my practice, maybe long 10 or 15 years back, a child was referred to me by a general practitioner with history of vomiting and altered sensorium. I thought this may be vomiting gastritis, but when I smelled vomitus, it was something else. It was very shocking that vomitus was suggestive of some organophosphorus. And then this child being medico-legal case, I referred this child to our rural hospital. I personally accompanied that child. We were treating that medical officer there, superintendent, few of my colleagues, pediatrician colleague, and we were treating that child. Unfortunately, at 3 a.m., there was no respiration, there was no heart, and child was dead. Can you imagine what was age of that child? That child was studying in 4th standard, and age of the child was hardly 10 years. This was really shocking for me, and from that thing, I have started giving lectures to parents. So, emotionally exposure to domestic violence, underlying cause of domestic violence and alcoholism in that home, and of course, these are the causes: substance abuse, stressors, disciplinary problems. Probably you know, in Kota, incidence of suicide was suddenly high. In last year, 2023, there were 24 cases of suicide. This year, up to maybe August or September, there were 13 cases of suicide. Why? Because again, there are so many problems, but one of the most important is disciplinary problems. On the top of it, some high expectations from parents, interpersonal losses, family violence. Remember that whenever family violence is there are more chances of behavioral disorder, and out of this behavioral disorder, few of the children may commit suicide. Sexual orientation confusion, sexual abuse. Nowadays, see that again, all these newspapers are flooded with so many news of sexual abuse and bullying in school. Depression and depression. I always say in adult they say that almost 80% of the suicide, in 80% of the suicidal cases, depression is underlying cause. Even it is proved beyond doubt in pediatric practice also, or in adolescent also, that depression is the cause of this suicide, and almost half of 10 to 15 years olds have reported feeling something is going on with them. Some symptoms of depression are there. Remember why we should discuss these cases, because as a pediatrician we should know how depression can be suspected. I'm not saying diagnosed because there are no tests as such, but depression can be suspected in children, and that's why though child may come for any other illness, you should interview that child, or you should interview parents. Okay. Then adolescents are low risk. They are at low risk, moderate risk, or high risk suicide. Low risk means what? Say, I will give you example. One child took 5 ibuprofen tablets after argument with his girlfriend. This was with some impulse. Told mother 15 minutes after taking pills. So there was no intention of successful suicide, no serious problems at home or school. Occasionally feels down, has a number of good friends, and no substance abuse. With all these things, and he immediately informed to his mother that his friend that he has consumed some tablets. So probably this is at low risk. Moderate risk, another example. Suicidal ideation precipitated by recurring fights with parents and feeling great. Remember, he wants to get back at parents. So, one of the reason is that this is some attention-seeking behavior of children, which child may manifest in suicidal ideation. Cut both wrists while at home, and then immediately he informed his friends that I have done such and such offense. Then parents separated. There were a lot of problems in school. One more thing, history of attention deficit hyperactivity disorder, ADHD. Remember that there are more chances of suicide in children who have some behavioral disorder, symptoms of depression which were not diagnosed, and he has difficulty in controlling temper. High risk, as I said, depression is there, no doubt. But if it is associated with substance abuse, if it is associated with family violence, if it is associated with some problems or alcoholism or some substance abuse in parents also, probably in such cases, child may develop depression, child may develop some other behavioral disorder, and there are more chances of suicidal tendency. Warning signs, as I said, there are very rarely suicidal tendencies don't just appear from the blue. But let me tell you few of the things. Even in 80% of the cases, depression is underlying cause or some behavioral disorder may be underlying cause. But exceptionally, few of the children may commit suicide suddenly or they live on impulse. I would like to give example from my own rather than practice from my friendship. One of my friend, he is from Parbhani. His father was admitted in ICU. As news of death is disclosed by doctor, he suddenly jumped into well, and he was no more. So these are some exceptions, but most of the children will give some number of warning signs, and these we should watch these warning signs. Which are these warning signs? Again, as I said, and I am again repeatedly telling you, depression and in pediatrician should be able to just wait for a minute. This is warning signs and risk factors: withdrawal from family and peers, loss of interest in previously pleasurable activities. He may be interested in some games, he may be interested in some music, may be interested in some other hobbies, but he suddenly withdraws all these hobbies. Difficulty in concentration on schoolwork, and scholastic backwardness may be there. Neglect of personal appearance, obvious changes in personality, sadness and hopelessness. So all these signs, they suggest that probably child is in depression. As I said, few children may give some clues, some signals, but others hide their problems, and uncharacteristic agitation and hyperactivity may be seen in few of the children. Okay. Low self-esteem and deprecating remarks. So patient may have low self-esteem. As you can discuss with this child psychologist, what is this low self-esteem, and probably child manifest with this low self-esteem. Talk or write without their about their suicidal thoughts. Generally, they leave some note or they may talk. I always say, ए मेरे दिल कहीं और चल, गम की दुनिया से दिल भर गया. अगर ऐसा कोई बोलता है तो probably remember that he may have some behavioral problem, or he may have some depression problem, and they should be taken. If there is note in family, or if there is note in somewhere he has talked with his friends, probably he may commit suicide. Any previous attempts at suicidal ideation, if suicidal ideation is there, or he if he has some attempts, probably he should take it very seriously. Serious depression in adolescents may manifest in several ways, as we are discussing. Depressed mood almost every day, crying spells, or inability to cry without any reason. Parents may not get any clue, but this child has some crying spells, a sense of एम्प्टीनेस एंड मीनिंगफुलनेस कि मेरी जिंदगी में अब कुछ नहीं रह गया है, मेरी जिंदगी में बाकी बचा क्या है. स्पेशली कॉलेज स्टूडेंट्स, especially after their breakup, it is very likely that they may commit suicide. Negative expectations of self and the environment. Again, this is the same low self-esteem, isolation, a feeling of helplessness, markedly diminished interest and pleasure in most of the activities, as probably they develop they lose their activities. Significant weight loss or weight gain, either they lose appetite or they gain maximum appetite, and they may lose weight or there may be weight gain. Insomnia or hypersomnia, they may sleep less or they may sleep more. Fatigue and loss of energy, feeling of a diminished ability to think or concentrate. We are pediatricians. We come across so many problems like this: abdominal pain, chest pain, headache, lethargy, weight loss, dizziness, so and so. Remember, my friends, that if few of these symptoms are associated with depression, I know one of my patient, both parents were executive, both were from industrial area, and their some 6th or 7th year old child was brought to me with complaints of vomiting. Every time child vomits, whatever she takes vomits. I have given some antiemetic drugs, but not stopped. As Mahad is very small town, they immediately went to Bombay. Child is investigated thoroughly, all endoscopies, then CT scan, and then this, and then all hematological investigation, everything. And ultimately it was nil, and they have given the same medicine which I have prescribed. वो फिर से मेरे पास आ गए और बोलने गया, यार डॉक्टर साहब ये तो वही दवाई आपने दी थी, ये इतना सब खर्चा क्यों हो गया? But my sisters, my staff members talked with that child, and my staff nurse observed that there is some problem in school. Probably she is poor in mathematics, and that's why he hates to going to school. Then I communicated with parents. I counseled them and said that give maximum time to your child. Take 1 month leave. Probably all her symptoms will stop, and to our surprise, all symptoms, vomitings and everything was stopped. So, if there are psychosomatic disturbances like this, think of depression or some psychological disorder in that child. Suicidal ideation. Ideation means they tried to commit suicide some or other time. But remember that if child either gives threat for suicide or he attempts unsuccessful suicide, remember that these children are more likely to commit successful suicide. So having seriously considered and or actual attempt suicide within the past 12 months was more among the higher age groups, so and so. As I say routinely, communication, just wait for a minute. Communication with parents and parental support, most of the time, either proper communication is not there with children. Amol, should we stop?
Please continue,
Tripti,
sir.
should we stop?
Continue. Sir, please
We
continue.
have more 20 minutes, sir. Please continue.
ओके, नहीं 5-10 मिनिट हो जाएगा. हे काहीतरी माझ्या ह्याचं प्रॉब्लेम येतोय रे.
काय स्क्रीन दिसत नाही?
माझे फोटो आपले सगळ्यांचे दिसत आहेत, पण स्क्रीन नाही दिसत मला. एनी हाव आय विल गो विथ दॅट. Communication with parents is the most vital asset against remember that even in my parenting lectures, I always tell that proper and healthy communication all the time with your children is the most important thing. If there is no communication in family, if there is some problems in the family, then probably the child develop more behavioral disorders. We are pediatricians or we are doctors. We generally keep confidentiality. But as far as these cases are concerned, or if child expresses his wish or will for suicide, remember that this confidentiality must be breached. Pediatrician should inform, must inform either parents or close relatives or friends or whoever who is very close to that child. Even I read in newspaper that probably the school is from Lucknow, and in Lucknow, one teacher was punished. She was punished because she never disclosed that child tendency of suicide to parents. So, in all cases, determination of the sequence of events that preceded the threat, identification of current problems and conflict should be disclosed to somebody. Remember that we are general pediatrician by and large. We are not expert. Still, if you come across any of such cases, it is your duty to seek professional help from any of the either psychiatrist, psychologist. Treatment modalities we will not go because I generally leave this up to psychiatry, and I tell them generally doses, what are the doses and whether this drug is contraindicated or not. But rather than medical pharmaceutical treatment, what is more important is psychotherapy and counseling. As the vast majority of adolescents who commit suicide have depressive symptoms, recognition and evaluation of clinical depression is essential. As I am telling you since beginning that identification of depression, especially in adolescent, is most important, and then counseling is the basic part of this treatment. Psychological counseling will help a teen to develop effective mechanism for coping with the problems. even as a general pediatrician, though I am a general pediatrician, I usually ask parents what are the problems and I counsel them. So many problems can be solved at your clinic also with proper counseling or with proper talk with child. What they need is love, encouragement, love and encouragement. Suppose you talk very nicely with them, probably so many problems will solve with your counseling. Why I am saying your counseling? Because parents believe you as a pediatrician. They will not go directly to any psychiatrist, they will not go to psychologist, but they will communicate with you, they will talk with you because they have a lot of faith in you. And that's why to keep this faith, you should study at least depression part of this psychological problems. I will not go into details. Cognitive behavior therapy for suicide prevention is one of the screening. You cannot ask child, अरे अरे भाई आपके दिमाग में कुछ सुसाइड के थॉट्स आते हैं क्या? No, you cannot ask. But there are some different scales where we can diagnose depression in various ways. Prevention, one of the most important part is lethal means reduction. There may be some lethal weapons, there may be some toxins, there may be some pesticides, there may be some rope, there may be some rings, and whatever may be. If there are cases that child is depressed or child have some suicidal tendency, if there is history of suicidal ideation, then you should lethal means reduction in home is most important. And last, strategies. There are a lot of strategies to prevent the suicide. Promote awareness. Remember, my friends, whenever I go in school, in 2 or 3 schools, they specifically warn me, सर वो सुइसाइड और उसके बारे में आप मत बोलते जाओ कुछ, क्योंकि हमारे पास सुइसाइड नहीं होती है. But remember, my friends, nowadays there are a lot of problems in adolescents. I don't know whether you have encountered or not. When I was talking with headmistress of one of the school, she said that nowadays, even in rural area, every boyfriend needs a girlfriend, and every boy needs a girlfriend, and every girl needs a boyfriend. If they don't have, then they go in depression. If they don't have, they develop some problem. If they don't have any girlfriend or boyfriend, bullying is there. And this is not only in public schools, this is not only in urban area, but this is nowadays very common in rural areas also. बॉयफ्रेंड है, गर्लफ्रेंड है, नहीं है, ब्रेकअप हुआ, ब्रेकअप तो हमेशा होता है. एंड इफ यू स्टार्ट रीडिंग न्यूज़पेपर मोस्ट ऑफ द टाइम दिस इज बिकॉज ऑफ द ब्रेकअप्स विच दे डेवलप इन देयर स्कूल्स. हमारे टाइम ऐसा जमाना नहीं था, बट एट प्रेजेंट children are developing, these adolescents are developing these problems. Strategies specific reducing domestic violence and substance abuse, because these are the two most leading causes of suicidal attempt. So domestic violence should be avoided. Whenever I go for parenting lectures, I always say that quarrels should be avoided in family, at least in front of your children, and substance abuse by any way should be avoided. Reducing access to convenient means, we have talked, reducing the quantity of doses. So all in all, if any child writes or expresses his desire for suicide, take it very seriously. Don't make a joke of it. Consider suicidal behavior a cry for help. Mujhe gino. This is again attention-seeking behavior. So a cry, whatever help he needs, you should give. Be willing to give and get help sooner rather than later, as early as possible, before this problem become worsening. Listen to them what they want to say. Ask if they are having thoughts of suicide. We cannot directly ask, but there are different ways that we can discuss with them. If they are acutely suicidal tendencies there, do not leave them alone either in their home. School में तो सब रहते हैं, but do not leave them alone in home or is professional help. Don't keep secrets. Discuss with your pediatrician, with psychologist or psychiatrist or your relatives. For teachers, know the warning signs, just which we have discussed. Know the school responsibility, as I narrated case of a teacher in Lucknow school. School should know responsibilities, and all these guidelines are given by National Association of School Psychologists in their conference. Encourage students to confide in you, because they should have full confidence in you. You should have proper communication with children. Refer students immediately. Do not beg a time, but escort the child to either home, because child may commit any problem in the way to home. Join the crisis team. Advocate for child. Tips for parents, as I said, know the warning signs. Do not afraid to talk to your child. And again, I will say, I can tell you, do not be afraid to talk with your relatives or close friends. Suicide proof your home, as I said, knives, pills, and above all, firearms. Utilize school and community resources. I don't know, in rural area there are no school community resources as such, but nowadays in every public school there are psychologists and on-call psychiatrists, so meet them. Take immediate action. Do not leave your child alone. If he has serious problem, serious depression, and he expressed his will and wish to commit suicide, do not leave him alone. Listen to your child's friend. वो जासूस होते हैं. Probably they will give you full idea regarding your child behavior, and do not listen to your child friends, and do not neglect what friends say. So this is all in all regarding suicide behavior in children. But remember, my friends, that this really tendency of suicide and successful suicide is really on high rise. And as a pediatrician, though you are general pediatrician, you should be aware of these problems and you should take proper care. So thank you very much, Amol. Thank you very much, everybody. Thank you very much, Trupti Mahatme, for giving me this chance. And probably I am talking after a very, very long time. And I would like to express my sincere thanks to all of you. Thank you very much.
The wonderful lecture by you.
Yes.
असं म्हणावं लागतं.
Wonderful. नाही असं म्हणावं नाही लागत. खरंच this is the need of the hour. We underestimate what depression, what we see in our days, but nowadays it is a routine problem because their mood changes like the apps of the mobile.
Apps and
So
mobile. I'm sorry, I forgot to talk regarding apps and mobile. Probably this is the culprit most of the time. And I have seen in one of the school, Marathi medium school, because of this app, so many children injured themselves. So probably apps. You please continue, Sanjay.
I'll share one. My batchmate having only single child. They are staying in Delhi. They are staying in Delhi. Only one child was studying in Canada. He invested his money, father's money, in some cyber game. He was supposed to leave the day two for Canada for his studies, and because he thought now it is he cannot tell his parents how he's lost his money in some cyber game, and he jumped from the 11th floor and committed the suicide. A very close friend of mine. So it means it's a very tragic. He also called the emergency number of suicide center, where we in India our suicide centers are always closed. They are just the name, for the sake of the name. They are open. They are for the emergency. But everything, when found out nothing came to his rescue, and he wrote a suicide note. I Baba, I am really very sorry. I mean, that's a thing. Means it is, you cannot say at the one moment right now you have seen a child and he's okay mentally, physically, and what he will do tomorrow, that you can't judge. So you need that eye, and you really need to be keep a eye on that
Very close
means
supervision is needed.
adolescent people, so that at least you can help some of them children to prevent from.
Yes.
It's a
Thank you,
wonderful
sir.
lecture,
Wonderful
need
session.
of our. I just want to ask my query. What is the DHS about DHS? That is self-harming, that is disturb self-harming in children. Do you come across these things?
Yes, yes, yes. But just a few days before, I was sitting with one of the social group. Of course, it was cultural group, and then one mother told me that few months back they were playing. All children, boys and girls, were having some game on app in their school, in some recess or something like that, and almost 25 children had some knife, using knife, and they cut their hand, rather than hands they had injury on their hands. Parents were not open in this. Headmaster and teachers, even they kept secret, because this was problem of their reputation. And self-harm is definitely increasing. As far as number you are asking, I don't know.
Yes, yes. That is a clue we can judge that child is been, if we can't
There
prevent
is
it.
some app game, as Sanjay pointed out. There is some game on mobile. Mobile is the worst enemy, and as Australia has taken this decision that no social media should be used by children like that. That is
Yes.
16
really
years.
need of the
Yes.
time in
Till
India.
16 years.
Huh? Below
Till
16.
16 years of age.
Yes, yes, yes.
I think this is in the same today's newspaper or something.
Even
Just
China has also banned very early. They have banned social media. Means even they have threatened the parents. If they means they decided time limits for the mobile use.
yes.
Yeah.
Chalo, wonderful lecture, sir.
Yeah.
Once again.
Thank you. Thank you so much, sir, for very eye-opening talk on such a sensitive issue. Dear, all life is precious, and sir is already highlighted many important points in his talk. And a few take homes to for all of us. First, to identify the warning signs. Etiologies can be varied. Even a small trigger can push the child into depression and leading to suicidal behavior. But identifying those warning signs as important, we being a pediatrician play a crucial role in challenging and addressing these mental health disorders. So as sir has already told us that screening can be done, and various screening tools are available online, freely available, validated tools like
Yes.
scared for anxiety, BDI for depression, and even ask questionnaire, which hardly takes 2-3 minutes for suicide. So these tools can be used by pediatricians as well. And sir has very well told the importance of parental connection, which is a prevention as such. So connection is
Connectedness,
prevention.
yes, yes.
Yes. And support for the children. 3H are important. So again, help, healing, and hope, which will definitely help to prevent the devastating consequences of suicides. So thank you so much, sir, for the wonderful talk. So we just have two questions.
Yeah.
One, how to keep children away from mobile? I think this is a
That is the most difficult question. But basically, parents should keep themselves away from
Yes, that I
mobile.
was saying.
Yes, yes.
First,
Parents
as a
are
role,
Whenever
we
at
should be
home.
our
Yes,
role models
parents
for
are
them first.
responsible for that. Gadget free day. I have given one lecture in one of the colleges. Gadget free day. गैजेट एक दिन के लिए पूरा बंद रखो. मैं एक बात बोलूं आपको तृप्ति कि ये मोबाइल बहुत खराब है ऐसी बात नहीं है. दैट इज नीड ऑफ द टाइम. इवन वी ऑलवेज सर्च इसका डोज क्या है उसका डोज क्या है ये क्या है वो क्या है किसका मैसेज आया है क्या नहीं आज कौन सी कॉन्फ्रेंस से क्या करने का है. That is need of the time. But as said very correctly, up to 16 years, this mobile should not be used. Of course, Indian Academy of Pediatric published a very good guidelines कि कितने टाइम तक मोबाइल यूज करना चाहिए. इवन अमेरिकन एकेडमी पीडियाट्रिक पब्लिश देयर गाइडलाइंस एंड एज माई वन ऑफ माई सन इज इन अमेरिका 2 साल तक उन्होंने ना मोबाइल बताया एक्सेप्ट to talk with your relatives or friends or grandparents. Otherwise, mobile should not be used. TV तो बंद था उनका. So it is like that. तो mobile in Marathi it is said that बोले तैसा चाले त्याची वंदावी पाऊले.
exactly.
अगर आप ही मोबाइल यूज करते हैं और आप बोलते हैं कि ऐसा करो वैसा करो, आप टीवी देखते हैं सांस भी कभी बहुत ही और बच्चे को बोलते हैं कि तुम स्टडी करते रहो, नॉट पॉसिबल, नॉट पॉसिबल. तो पेरेंट्स मोस्ट इम्पॉर्टेंट थिंग इज पेरेंट्स आर देर आर नो बैड चिल्ड्रन बट बैड पेरेंट्स इंडीड. तो मोबाइल बंद करने के लिए पेरेंट्स के लिए कुछ गाइडलाइंस देनी चाहिए.
Perfect. Yes. Second question for Dr. Preeti Madam by Dr. Chitra Kulkarni ma'am. Adolescent obesity drugs are recently available in the market. So when to give these drugs?
Madam, kindly
Yeah.
unmute.
Yes, sorry.
You are audible now.
First and foremost, if the adolescent's obesity is associated with comorbidities, for example, any pubertal problem or any metabolic problem, pre-hypertension, pre-diabetes, such a thing, and with a strong family history of insulin resistance, if there is an obesity, diabetes, hypertension in parents and grandparents, in these cases, first 3 months we have to give the medical nutrition therapy along with exercise. And if it is not, there is a weight loss of at least 5% in first 6 months, then we can think of the pharmacotherapy.
And so many times we see the drug metformin in the prescriptions of the means endocrinologist,
Yes,
even though
yes.
they are even though they are not diabetic.
Actually, I already mentioned in my lecture, though the FDA is not been recommended metformin for its use in obesity, but this is off-label been used on wide scale because metformin decreases the appetite. Because obesity in such, there is two things: increase in quantity and increasing for faulty diet. So out of that one we can tackle, that is we can at least reduce the appetite. That is the intention behind prescribing the metformin in obese children.
Thank you.
Okay,
Yes.
thank you, ma'am. Davarkar sir, there is a question for you in relation to suicide. Mirror or copycat? Please explain.
Pardon?
Mirror or copycat in
I
relation to
don't,
suicide.
I don't know what is the meaning of this
Chitra
question.
ma'am,
Sanjay,
Chitra ma'am,
Preeti,
Chitra ma'am, please unmute and talk. Ask your question.
So, sir, I want to
if
ask
anybody can
about
answer, I will be very happy. Welcome,
No,
Chitra
she is
Kulkarni,
asking.
madam.
Just listen,
yes,
sir.
sir.
Chitra ma'am is
Yes,
asking.
We often get cases of suicide done in the same way, and then it is like called as copycat suicide. But how to get that symptoms or signs or clues like copycat suicide? Like after the famous actor suicide, there were nearly 15 suicides like that. What he had done.
Frankly, I never
Yeah.
across such terms. Probably maybe very common in with psychiatrist or psychologist.
Yes, sir. Thank you, sir.
Whenever somebody, madam, what I few times I have heard, whenever somebody plans for the suicide, he gets also questions how to do suicides. Nowadays, it's era of mobile and Google and everything you can search. What is good and what is bad also you can search, and from where you can get any idea with which will get a painless suicide with minimal interventions, with means early death and all these things. And for this, the people do means see ki in the past the particular person has done a suicide in this fashion or in that particular fashion. So they want to copy that particular way because they also don't know exactly ki how to go for it, how to go for the suicide. Someday they have decided, I know nothing is left in life.
Sanjay,
But then the question comes.
This lecture was on how to prevent suicide.
Uh-huh.
Now you are giving hints how to commit suicide.
No, sir, because
Just I'm kidding. Just I'm
I
kidding.
have gone through the very real people
Yes,
who
yes,
are
yes.
when I have seen the patient who has seen with the mother and the patient, they came to my chamber, and I have examined the patient. They gone back and somebody said in the evening the mother has done suicide. I said, how can she was so happy at that moment in the afternoon, and how can she do the commit a suicide in the evening? So I mean, so there are an n number of cases which I found, and then I asked few parents which in their family something happened, and they told me ki this time in the warning signs we were getting something like this, but we could not acknowledge it in that time. And that's why he was searching in the mobile particular sites he was visiting. But that time they thought ki he was just searching anything. But then they realized ki he was doing something because he was planning for something.
These are the signals given by, I mean, individuals, and that should be picked up in time. Yes, yes.
So one last question we will take. Does for Preeti madam, does metformin help in pre-diabetic obese kids?
Definitely, but only metformin without going for the lifestyle modifications. That is a medical nutrition therapy along with the increased physical activity. Only metformin will not be helpful in prediabetes children. Along with metformin, we have to go for the MNT along with an exercise.
Yeah. So thank you, ma'am. Amol sir, should we conclude?
Yeah, it is 10 to 9.
Yes, yes. So, thank you so much, everyone. Thank you, today's speakers, Dr. Shekhar Tabadkar sir, Dr. Preeti Fatale madam, for really, really wonderful and practical talks. I thank Dr. Ram Gopal Chizara sir, Maha IP President, Dr. Amol Pawar sir, Secretary General Maha IIP, for wholeheartedly supporting the program since last 2 years. I do thank Dr. Atul Kanika sir, who is the Chief Coordinator, PATH IIP. I thank Dr. Rajendra Kulkarni sir, who is MMC observer for today's session. I thank Dr. All the dignitaries which are present here, Dr. Sanjay Pakmore sir, Dr. Kute sir, Dr. Sangita Loda madam, for being there for today's session. I thank my colleague coordinators, Dr. Sulba Pawar and Dr. Reena madam. And I thank all the delegates for your wonderful response to the program. More than 250 delegates were present. The highest was 277, and the response is increasing for each part session. That is really wonderful. It denotes that awareness is increasing for adolescent health. And in the end, I thank Dr. Pallavi Dharmadikari madam for excellent technical support till the end. Thank you so much.
Thank you
I
so much
also
for the
thank Dr.
opportunity.
Trupti Mahatme, who
Yes.
has coordinated maximum programs in last 2 years. And I also thank Dr. Vishal Rao, who is our digital wizard, who makes all these flyers, catchy flyers to all of us. And thank you, Nasik IIP team, Nasik AHA team, and all entire Maharashtra IIP Executive Board members and President-elect Dr. Sanjay Pakmode sir for their kind support in last 2 years. Thank you. Thank you one and all. Thank you, Preeti
Thank
ma'am
you so much.
and Dr.
Thank you.
Shekhar
Thank you.
Dabadkar sir for
Thank you.
your innovative session, informative session. And Shekhar Dabadkar sir just gave us the practical tips in counseling these adolescents. And Preeti ma'am It was a very comprehensive approach to childhood obesity, and you have given many examples. You have given many examples
Cases.
of obesity, this thing, childs. So thank you once again to all of you. Thank
Yeah.
you.
Thank you. And Dr.
Thank you,
Fructuates
thank you,
and
sir.
round of applause
Thank you,
because she
Amol.
has
Thank you.
moderated the
Thank you,
sessions
Preeti
very
ma'am.
nicely.
Yes, yes.
Thank you, ma'am. Thank you.
Okay.